My name's Simon Barrett and I'm a tissue viability lead from sunny Hull. If anybody's familiar with that, it's up north near the Humber Bridge. Now usually Chris, who's just leaving the room now, gives me 45 minutes and says if you're not out on that time, he basically comes and sorts me out. This day I've got a traffic warden as well on my tail, so I best be quick, haven't I? So yeah, as I say, I'm Simon Barrett, TVN. I currently practice in Humber. I've been a tissue viability nurse in the community for about 14 years, and prior to that about 4 or 5 years in the acute trust, and prior to that my background was vascular, general surgery, a bit of max vax, a bit of cardiology, a bit of gastroenterology. So you should be looking at me and saying, God, it doesn't look too bad. Doesn't look too bad for all that years experience. I started when I was 9, I might add. So, quick question to you all, see if you're all still alert and switched on. What's the most important part of wound care? Which comes from assessment. So, if assessment's the most important bit, do you all think every day when you go to work, I presume you're community nurses, are you? Just put your hands up if you're community nurses. Practice nurses? Acute nurses? Podiatry? Anybody just for a free meal? So there's a vast majority are either community or practice nurses, 1 or 2 sprinkled in of other specialities. Would you say when you go to work you feel that you get on a hamster wheel, you run and you run and you run and you run, and you get off at the end and then you've got to do your electronic records? Yeah? Well, do you want the bad news? Or the good news? The bad news is I don't think it's going to get any better from a personnel point of view. I don't think we're going to get many more staff, because if you look at this historically, going back to my day, which was the 80s and the 90s if you like, in the acute, we used to have 6 in the morning, 3 plus 1 on a late, and 3 if we were lucky on a night shift, and that was for 28 beds, of which 4 was high dependency. I don't think it's got any worse, I don't think it's got any better. What I do think is though the dependency of those patients has increased, so those that were on our high dependency are probably a general ward-based patient now, and that means those patients have knock-on effect into the community. So the intensity of the nursing care, if you like, has increased. So that means our workloads increase. Now the only way that we can actually get this better in the community, certainly, because in the community about 54-55% of your workload is wounds. So the only way that we can improve it is if we use dressings that last longer, that may cost a little bit more, but you've got to get out of that ritualistic practice, if you like, of going on a Monday, Wednesday, Friday, just because that's what we've always done for the last 20, 30 years. We've got to go based on the length of the wear time of the dressing, and not when the patient dictates, it's when we see it clinically appropriate. And that is the only way we're going to get some time back, because I've no doubt you're all the same as me. If you're like me, I finished work last night in Whitby, drove back home, I got home about 6:30, then I started doing my electronic record keeping till 8:45 last night, and you just think, you know, this is a long day, from 8 in the morning into it till 8:45 at night. It's a long day, and then it's a long drive down here as well. And when you end up in a bus route and you're travelling around a bus route as well, I'm thinking, oh no, fans coming as well. So the most important thing that we can do is make sure that we do a good holistic assessment. If we get that good holistic assessment bit right, then there's a fairly good chance that we'll enter into a better relationship with the patient. They'll be more compliant, concordant, and we'll get better outcomes. Because we did a survey a few years ago supported by Coloplast, and we looked at 5,000 wounds in 5 organisations, and the percentage of non-compliant patients was 25% plus across that 5,000 wound population of chronic wounds. So that means, in theory, if you was like our organisation, you've approximately got 850, 900 wounds, you've got a budget of £1.1 million to provide all those dressings, that's about £300,000 that's inappropriately used because the patient's been non-compliant. And when you drill back as to why has that happened, it's usually because we haven't had the time at the beginning or spent enough time at the beginning doing that holistic assessment. We've missed bits of it off. Now, because of the sequin that we've got running through the country on wounds at the moment, which was running 2017, 18 and into 19, we've got to show that we've improving our practice with regards to assessment of those chronic wounds. Now, we did a baseline assessment last year in Humber. We had to pick 150 wounds, looked at 150 wounds, and out of those 150 wounds, or let's just call it 100%, how many, oh wait, this is on camera, how many do you think had a full holistic assessment out of 100? Don't be shy. 28. Any more offers? 60. It was in between. It was about 44%. Now, in actual fact, my first thought was, I was expecting it to be around the 80%. Maybe I was dreaming. But I was thinking, maybe 80%. Then, a little bit of relief came across me because I thought, right, it's 44%. That's my baseline number. The commissioner's now going to say to me, right, I want you to uplift it. Now, if I'd have been on 80% and they'd have said I want a 10% uplift, that would have been hard. Now, to get a 10%, 15, 20% uplift on 44, you can put some simple things in place to improve it, like a tool that looks at your assessment. You can do your electronic records slightly differently, so we make sure we tick all those boxes before we can come out with an end result. So we put some things in place, including this, and within 6 months we moved it from 44 to 66%. So the commissioners were really, really happy with us. And they said to me this time, which is this October I've got to have it in by, I only need to take a sample because they were that impressed. I only have to take a small sample for the local commissioners to say, look, we're still achieving that target or that percentage. So that's really good news for me. So this tool is actually called the Triangle of Wound Assessment. And what I think we've focused on too much in the past is the actual just the wound. We go in and we focus directly on the wound as opposed to the whole person and the skin. Skin's what? What is it? Largest organ on the body, isn't it? It does multiple things. Now, if I was to have a heart attack in front of you now, hopefully I won't because I've got young children at home, but if I was to, hopefully because you're all CAN qualified nurses or caring people, you will run forward and you won't just Finney Jones me, you'll actually give me mouth to mouth and bring me back to life. But if you've done your recent training, you won't even do mouth to mouth anymore, will you? No, it's not appropriate anymore, but I'm quite happy if you want to. So, you'll come forward and you'll resuscitate me. If I was to trip over this mat though and lacerate my hand as I went down, you'd probably just go, you silly old devil, maybe root around in your bag, see if you picked anything up, and you might come forward and put a dressing on my hand for me. You might do, but you won't do it in the same urgency as you would if I was having a cardiac arrest. But it's still an organ, isn't it, that's doing multiple things. And if we don't make an impression on the way that we assess that patient in that initial period of time, we will end up with a chronic complex wound that won't heal. And then you'll be saying maybe 6 months, maybe a year, maybe 2 years down the line, hey, this isn't healing as we expected. And is it all because we didn't spend that time at the beginning? So we've got to have the optimum environment. What is the optimum environment? Warm and moist. Do you know where that comes from? Pigs. Did you say pigs? Yeah. Who's saying it? They're doing it out moving the lips. Pigs. That lady. Pigs, yeah, it's George Winter's work, 1961-62. What he did, if anybody's not familiar, he scored some insults with a blade onto pigs. He covered half the wounds with a film dressing, he left half exposed to the outside air. And what he found was those that had the warm, moist environment healed that bit quicker. So there you got the theory of warm, moist environment for healing. So that's why we've got all these dressings that are out there at this moment in time waiting for you to have a look at to make sure that you're putting the right ones on at the right time for the right length of time. So it's our job, we are the key holders, if you like, to that door, to that wound. So it's our job to make sure we do that assessment, we choose the right dressing, and we review its progress. We also need to work as part of a multidisciplinary team, don't we? Making sure they've got the right nutritions in, making sure we're working with OT for seating, physiotherapy for mobilisation. Do we do that as well as we should do? I probably don't think we do. I notice in our area at the moment, what we're doing though, we're all working within the same office, so communication has improved dramatically and things are starting to pick up. We've all got wound care formularies, hopefully. They've been designed or brought to the workplace to make sure that we're quality and cost effective. It should be a tissue viability group. Your medicines management will all have contributed towards that, and possibly procurement. So it should be a cost effective way of managing your wounds. But again, a formula is only as good as the people that use it, which is you. Because effectively you could go like kids in a sweet shop, couldn't you, and say, I'll have this, this, this and this, and you might put a sandwich layer in a dressings on, which would be totally inappropriate. When I was doing some training yesterday up in Whitby, they said, we don't do sandwiches. So I said, so if I was to do an audit of your wounds, I won't find at any time a combination of a hydrogel, a hydrofibre, a foam, a super absorbent, and then a bit of gauze on top just for good measure. They said, nowhere will you find it. So I'm auditing it next week. So the triangle of wound assessment, what is it? Basically, as I say, it looks at the wound bed, the wound edge, and the peri-wound skin, and it's about bringing it all together, because you will not get a wound to contract unless you've managed that area around, that surround of the wound margin. Otherwise, you won't get the way I would describe it is, if you was an Olympic swimmer, you stand on the side, don't you, on a little platform, a springboard, you dive off and off you go like the clappers, you swim like mad. Now, if you haven't got that springboard on that wound margin, what happens is your epithelial tissue will jump and it'll belly flop straight into the wound bed and it won't progress across the wound. So it's really important that we look after that wound margin. Keep it hydrated, keep it protected. So we must always remember the patient. Like we were just saying a minute ago with regards to the multidisciplinary team, have we thought about malnutrition? We see some people as being big people, they must be eating and drinking well. That's not necessarily always the case, is it? If you've got a large wound leaking large volumes of fluid, then there's a fairly good chance, if it's a chronic wound, then it's like leaking large volumes of protein. Are we putting that protein back in routinely in the form of supplements? I don't think we are sufficiently well, so maybe we need to think about that. And if it goes outside of our knowledge base, let's bring in those multidisciplinary team members. Reduce blood supply, so does the patient need replumbing? If you haven't got blood supply with oxygen down to that limb or that peripheral area, then it's not going to heal. The same as a pressure ulcer. Effectively all it is, isn't it, is that you're stopping the oxygen supply to that area, cells senesce, cells die off, and you end up with an hole in somebody's skin integrity, and it's called a pressure ulcer. The same sort of thing with leg ulcers. Have we assessed a break in the skin integrity? If it's been there for 6 weeks or longer, it should have a Doppler ABPI, according to the Royal College of Nursing. Are they being done on time? I'm not convinced again that they are. And my question is, why are we waiting 6 weeks? If somebody's got a break in the skin integrity, why do I wait 6 weeks? Why do I, as soon as I see that patient, as part of my holistic assessment, let me check that Doppler ABPI, let me check the peripheral refill, let me palpate the pulses, let me see if it's warm, let me see if I've got hairs on the leg, is it white, shiny, hairless? Let's start putting that picture together. If you like, it's almost like paint by numbers, isn't it, until the full picture's formed. What medication is the patient on, and do they know why they're taking the medication? How many patients do you have that present shoe boxes of medications to you on first contact? There you are, that's all my medication. Why are you taking all these? Oh, I don't know, the doctor just gave me them years ago and they've carried on taking them. How many people are taking Nicorandil, which is known to induce ulceration, certainly around the anus and also potentially on the legs? So do we need to consider that? Cytotoxic drugs, chemotherapy that's been introduced is going to delay and slow that process down. The same as radiotherapy. Obesity, as I've already mentioned, we think because we carry a little bit of extra around our midriff, then we're fine. But what happens if we have an abdominal acute wound that dehisces? Then it means, unfortunately, because of that fatty tissue, the oxygen supply is not going to reach it quite as well. So we either get ourselves some of those superhero pants, you know, like the Incredibles, and pull ourselves in, or we get as trim as we possibly can, certainly in preparation for theatre. Post-circulation, we need to reperfuse, like I say, refer them through to vasculars, the plumbers. Psychological status, does the patient want to heal? Because how many times, even going back to when I was a student, people used to say, patients like the contact with the district nurse, it's their only contact with the outside world. Unfortunately, you people, me people, we don't have that time, unfortunately, do we? Because in the days in the 80s, we might have only had 10 contacts a day. Now, I dare say it's in the 20s, I was speaking to a district nurse the other day who worked from my wife's base, and she'd done 29 contacts that day. 29 contacts. How on earth do you do 29 good quality contacts? So the patient might not want to heal. They might want the outside contact. It might be that they're taking illegal substances, and if they have an open wound, they can actually claim more benefits. So they might not want to heal for that reason. There's the infection risk. Infection's a massive, massive issue, isn't it? And it's about being able to recognise, when do I treat with a topical antimicrobial? When, as a last resort, do I need to use an antibiotic? How long do I use an antibiotic for? Just out of reference, for a chronic wound, how long would you normally use an antibiotic for? Maybe you wouldn't. 2 weeks, thank you. I'll agree with that. This lady said at the front 2 weeks. Most GPs, most pharmacists will say a week. The problem is, if you treat a chronic wound for only a week with antibiotics, I guarantee it'll suppress that infection for that week. You'll leave it another week and it'll flare back up. So you need 2 weeks. The same as, if you look at the consensus documents on infection, you need to treat it with a 2-week challenge on that infected wound by using topical antimicrobials as well. I would also go as far to say there's consensus documents around that you need to disrupt mechanically any potential biofilms. So you disrupt the biofilm mechanically, put your topical antimicrobial on, and if you do need antibiotics because it's spreading infection, then you'll use your antibiotics as well. You should only really swab when you suspect that you're going to need to use an antibiotic. Other than that, there's not really any main reason, because the topical antimicrobials that you'll use are like Domestos. Do you remember it? Kills all known germs dead. Well, it's about 99.9%. A lot of your topicals will kill about 88 to 92% of bacteria, so they're not selective in that way. So, reduced wound temperature. Do you remember the days in the 80s when the consultants were called gods? And they would come onto the ward and say, I'm coming back at 2 o'clock, strip all the wounds down and I'll be here. So you'd strip them all down, put a paper towel on the top. Hey up, he's not come back, must be running over. Oh, let's put another paper towel on because it's all drained through. By the time he eventually comes, just on tea time when you're about to do dinners, you've got about that much layers of paper towels, haven't you? It's amazing how that sterile paper towel could protect the wound. And then you had the difficulty of trying to remove it, didn't you? Because you got all the shed on the wound bed. So hopefully we're not doing that anymore, because every half an hour that we strip a wound down, it takes 4 hours to get back to body temperature. As that lady's already alluded to, we need to keep it warm and moist. Not wet, not dry, just warm. Is there any maceration? If there is, we need to make sure that we rehydrate that skin and protect that skin and provide that springboard for that 100-metre sprint across the pool. Per wound management, that's us. If we don't get that assessment bit right, make a good diagnosis, make a good treatment plan that's documented and our colleagues can follow it, then we're going to end up with a delayed wound healing process. Patient compliance, we've mentioned, we need to get them on board, don't we, right from the beginning, get them involved in that care. Unrelieved pressure. Pressure ulcers in the day, if you like. It's amazing, isn't it? We used to say, hey, in my day, we didn't get pressure ulcers like you do today. Was that true? Was it true that in my day, we blew oxygen at people's bum? We put egg white onto people's bum? Yeah? We did it, didn't we? Was there any evidence behind it? No, there wasn't. There was no evidence whatsoever. Blowing oxygen at somebody's wound, there's no evidence. But watch this space, because in a couple of years, I reckon there'll be some mechanical device that will deliver oxygen to wound beds again. It's not far off, actually. But the evidence was very low then. And people used to say, oh, put egg white on because it's the protein onto the wound bed will allow it to heal. It didn't. What caused the wound to be in a better situation by putting the oxygen on and the egg white? What happened at that time? Regular repositioning. You offloaded the pressure, the skin reperfused, so the longer you took actually and putting the egg white on, or even in them days they used to talc, didn't they? Let's talc as well. In actual fact, it only worked because it took the pressure off that point and you was rotating the patient around. So it was fantastic in that sense, but nothing more, nothing less. And we've already mentioned substance abuse. So, going on, what does the wound need? Well, as we've already said, it needs a holistic assessment. It needs a wound and skin assessment to make sure we're looking after that large organ. It needs to make sure that we evaluate what we're doing continuously. We need to have a management plan that's clear and concise and all of us can follow, and it shouldn't be changed just because we fancy changing it because our colleague goes in a week later and doesn't agree with what we've said. Unless there's any real reason, we shouldn't change. Documentation, is it good enough? Is it legible? Will it stand up in a court of law? Because you don't want to be challenged by one of those blokes with the grey wigs on, do you? Environment, you've already said we need warm and moist. Have we created that with our dressing? And have we chosen the right dressing at the right time for the right length of time? Have we avoided those sandwich dressings? Hopefully we have. So the triangle of wound assessment offers a simple framework that looks at that wound assessment. It has a management goal system and it has a treatment outcome. So the full wound assessment should include, I don't know whether you can see these, so I'll read them up to you, but the wound bed should have an assessment of tissue type, exudate, and all things linked to it. The peri-wound skin should have a consideration of maceration, excoriation, dry skin, hyperkeratosis, the scaling, and any callus. Those things that are there and present at that time will need to be managed appropriately. The only time I would say to you not to remove dead and devitalised tissue is if you haven't got an adequate blood supply. So if you've got somebody with a black heel, as I came across two yesterday, if you've got somebody with a black heel, one, I would make sure that you do a Doppler ABPI, or at least put the probes on, listen to the sound, is it biphasic, triphasic or monophasic, and make sure you have that diagnosis as to whether I should leave that black necrotic tissue intact or whether I need to consider autolytically debriding it. And obviously only start to consider debriding if you've got a good blood supply. We then look at the wound edging again. It's the same sort of thing, maceration, dehydration, and is there any undermining? Do you all know what they mean by undermining? Because the number of people that say, what is actually undermining? Are we all familiar? Do you want me to mention what it is? Undermining is basically, you think about it, up north in the coal mines, they used to drill a hole out, didn't they? So they'd go down to the level of the coal and then they'd start to man horizontally, so it would undermine. So you would see a small hole on the top, go down the shaft, and then you would man outwards horizontally. So that's the undermining. So all it refers to is, you can see a hole on the surface. Does it go directly down, or once it gets down to the base of the wound bed, does it then undermine horizontally under there? And you need to establish how much that's doing. What we mustn't do when you come to doing your dressing of your wound is don't pack it tight. In my day, we used to have competitions of packing Usol, hydrogen peroxide, acetic acid on wicks, and we'd pack it down tight. Now, you should never do that, because if you do, one, you're causing a pressure point because you're packing it in tight, and two, you're restricting the exudate from coming out with that bacteria, so it'll all pool at the bottom. So what you should do is just layer the dressing in so that it doesn't compress and cause an actual pressure point in there, and it doesn't lock the fluid in. So the wound bed, from a triangle of wound assessment point of view, what it looks at is the tissue type: necrotic, sloughy, granulating and epithelializing. You tick whatever you see in front of you, so it allows you to start to outcome track. So what we've got, you can get this onto your electronic records and it'll allow you to chart it. It'll also help you meet your sequin targets if you're involved in your sequin targets. It then goes on to look at exudate levels. Is the level dry, low, medium or high, which is a little bit woolly, isn't it really? But there's nothing an awful lot more scientific than that at the moment. It then looks at the tissue, at the exudate type. Is it thin, watery, thick? So we're looking at the viscosity. Is it like thick custard coming out, or is it like a nice glass of dry white wine, which you all might need when you get home tonight? Just remember, when you do though, just think of it as exudate coming from a wound. So you'll save yourself all those calories and all that money when you're drinking that wine. Is there any infection? So is there any evidence of increased pain, inflammation, local warmth, abscess, any pyrexias, any edemas, or any further wound breakdown that includes bridging and pocketing in the wound base? Then we take it down a little bit further and we look at local infections and your spreading infections. So effectively, this is your aide-memoire to wound assessment, if you like. This is the way to help you make sure you've done all the right bits at the right time at the beginning that will allow you then to start to develop your management plan and to help you to start your treatment plan. So, it says, going back, the wound edge then. So it asks you, is there any maceration? Is there any dehydration? Is there any undermining, like we've already mentioned? And are there any rolled edges? Because if you get a wound with a raised rolled edge of hypergranulation, then you may need to consider, is there something going on here? Now, 95% of those wounds will be because of bacterial burden. You'll get hypergranulation, it'll go from being red to like a liver red, it'll become static or it'll increase in size. But 5% or thereabouts of those wounds that are showing hypergranulation, and how I would describe it would be Mick Jagger's lips. You know, when he was younger, he had big lips that raised and rolled. If you see Mick Jagger's lips occurring on a wound bed, then it could be a sign of a malignancy occurring. So you need to get them referred through via whatever your pathway is to either dermatology or plastic surgery and have a biopsy done. My first thought was, though, while you're waiting for that referral to come through, treat them with a topical antimicrobial first and see if it'll dampen down that inflammatory response. So the peri-wound skin, similar sort of questions. Have I got any maceration that I need to manage? Any excoriation? Because excoriation feels like a burn to the patient. So how are we managing that appropriately? Is there any dry skin that I need to rehydrate? Any of that scaly hyperkeratosis that I either need to remove and then hydrate? Otherwise, again, there's going to be potential cracks and roots for infection to get in. Is there any callus there? If there is callus around that wound margin, then it might be that we have to involve the podiatrist, get their blade on it, and they'll become like Zorro, don't they, once they're let loose. But again, they're much more highly skilled than I am to start removing that callus. And is there any eczema? And what's the root cause of the eczema? Do we need to treat it with steroids? Do we need to refer through to dermatology? Is it something that we can manage? Is it something they've just changed in the way that they've washed the clothes or come into contact with? Setting management goals then is step 2. So again, it all links in. Once you've identified the problem, the management goals are obviously to address the problems that you've identified. So it could be removal of non-viable tissue, management of exudate, management of bacterial burden. It could be management goals for the peri-wound skin of management of exudate, protection of skin, rehydration. So whatever you identify, you will then provide a solution. And Coloplast, who've worked with a group of TVNs to develop this tool, also have a board game that's really interesting when you want to do any training with your staff, because the board game's laid out flat, you're given a scenario and then you have to identify the problem, then you find the solutions. And I use it as an aide-memoire for our staff, you know, when they're doing their OSCEs, and the feedback's been brilliant so far. So step 3, choosing the right treatment plan. Again, this really is down to you. You've assessed and identified what the problems are. You're now looking at that holistic picture. So the treatment should include primary and secondary dressings, any relevant skin care, and always consider what the root cause of this wound was. Because wounds don't just occur for fun, do they? Unless I was to trip, I'd suffer a traumatic wound potentially. But most wounds are there and stay there because there's an underlying issue with the body and the patient, and they're not fit to heal. So it's about us trying to be the Inspector Clouseaus and finding out what it is exactly is the problem. So I'm just going to go through a couple of case studies. So this one's Neil. He's a 40-year-old gentleman. He's got a dehisced abdominal wound following gastric surgery, and then he had a hernia and that dehisced, which is the wound that he's left with. Right, looking at this wound, I hope you can all see it. Is there anything that stands out to you straight away that makes you think that's not going to heal? Is a beast. Yep, he hadn't used his incredible pants, has he? So his obese is one reason. There's quite a few. Skin folds. 2. Anything? There's more, as Jimmy Cricket would have said. Pardon? There's undermining. Yep, you can see a shadow on that wound margin to suggest it's undermining. So we need to know where to. Anything else? There's a little bit of overgranulation. Yep, we're doing really well. Slough, yeah, there's a bit of slough there that needs to be removed as well. Anything else? There's one more thing that wouldn't have happened in my day in the 80s because we had scrotal ferrets employed to do it. Hairy, that's it. Who said that? Yeah, hairy. He's got hairs ingressing into the wound, so the wound will be looking at that and thinking, hey up, I've got foreign bodies going on here, and they're going to react against that, so it's not going to heal. So we need to clean away those hairs from around that wound margin. But quite honestly, you identified all the problems that this gentleman has. So if he loses weight, he has the dietitian involved, he has some protein supplements to replace the loss of exudate that's coming out of there with the protein in. He has some good wound bed preparation to get rid of that slough. We look at the undermining, and hopefully we should be able to get him to come together. He's only a young chap in his 40s, so he should heal fairly quickly, and he did. Once we put the right dressings on, clear those problems away, that's exactly what happened. And it does need to be almost as simple as that. Identify the problem, find a solution, put it into your treatment plan and continue to evaluate it. So all we did was we used the triangle of wound assessment to document, was there some slough there? Yes, there was. What was the level of exudate? It was high. It was thin and watery in viscosity. And then there was some localized infection, as well as those other issues that you've already identified. Thank you very much. It's interesting because he went back to the surgeon, and the surgeon said to him, well, it wasn't the same surgeon, it was a locum that had come in from Italy. And he said to him, shall I try and do my Italian voice? Yeah. No, I can't. So he said to him, you need to go to your local supermarket and get yourself some honey. So this chappie thinks, oh, he's a doctor, he must know what he's on about, goes to the local supermarket, gets a tub of honey, comes back and says to the nurses, hey, the consultant said that I've got to have this honey put into the wound. So they rang me up and said, Simon, he's got this tub of honey, what do you think? So I said, what do you think? So they said, well, we shouldn't put it on. So I said, exactly, you're registered with the NMC. If you go and put something on that's not licensed, then you're accountable. So I said, you've answered your own question. I said, if he needed some Manuka honey, then we'll get it prescribed. Did he need it? Probably not really. We can lift away that slough mechanically quite easily and quite quickly, can't we? And start to prepare the wound bed without putting honey on. Just out of interest, is there anybody in the room that still uses hydrogen peroxide? Has anybody used it ever? Am I the only old one? Oh, there's a few going up now. We can still raise our hands, you see. We can do it. In the old days, for you young ones, we used to use hydrogen peroxide, acetic acid and usol and paraffin, which was basically bleach. And what we'd do, we'd put it in a little gallipot, put ribbon gauze in, wind it round our forceps, then we'd feed it into cavities, and it'd kill bacteria, and it did it really well. But the hydrogen peroxide was like this effervescing, bubbling stuff. So you'd be with your trolley, trotting along, all looking the part, and there was this effervescing fluid. And you used to think, oh, I'm like a bit of a mad professor here as I'm going there. Oh, yeah, I can get a foot in today. My mate said, well, I got a foot and a half in. Now then, it was stopped because, one, it was very toxic, but two, it was very painful. It was very painful. But it did work. So does anybody use it today? Anybody? Spot on. It is a byproduct of honey. When honey reacts with air, it causes hydrogen peroxide. So the stronger the form of honey that you put onto a wound, the higher the risk you have of causing more pain. We know when the patient says, oh, it's quite painful, this honey, and we say, oh, it's got an osmotic draw, which it has, it pulls fluid out, but it's because of that hydrogen peroxide, and that's why it's such a good antimicrobial killer. But it's hydrogen peroxide in its natural format. So just be aware of some of those things. I mean, if we could induce the use of usol again, bleach, in a format that was non-toxic, then that would be ideal. Now, it is being used again, but it's used in dentistry now. So if it can go in your mouth, then there's going to be a way forward soon that it comes back to wounds, I think. So assessment of the wound edge, again, basically, same sort of questions. Was there any maceration? Yeah, there was a little bit. There was some undermining, and there was that rolled edge, but it wasn't malignant. It was just related to the bacteria. The assessment of the peri-wound skin, well, on this one, we've got a little bit of maceration there, so we can protect that, and we can prepare that surrounding area, can't we, by removing some of those hairs. Unfortunately, we no longer employ the scrotal ferrets. The management plan was to remove that non-viable tissue, manage exudate, manage bacterial burden, and protect that surrounding skin. So all the things that we would normally do as nurses in our day-to-day way of working. The solution, if you like, obviously Coloplast make biotin silicone. I don't know whether it's on your formulary. It's on my formulary. Fantastic silicone-based foam. It's really good at absorbing. The best thing about it, though, is it conforms into cavities. So as long as it's not too deep a cavity, it can go in. But where there's undermining like that, you would need to put a filler in. All right. Case 2. This isn't my case study, so I can only briefly talk about it. But the bit of history is 28-year-old male presented in emergency room with a pressure ulcer that's been there for 8 weeks. He's got a previous treatment history of silicone gauze compression and bandaging. And they've been trying to relieve that pressure, but to no avail, basically. He's immobile with a neurodegenerative, that's it, try saying that one, degenerative disorder. So he's got this small ulcer, it's fairly punched out, that you may mistake, I suppose, because of the way that it's so defined, for an arterial ulcer. But it's a pressure ulcer, and it's being caused by his seating in his chair. So 1, there's an issue with his chair, which needs to be resolved. 2, there's an issue with his repositioning, and then you start to focus, if you like, on the management goals for the wound bed. So it's remove that non-viable tissue, manage the exudate. Again, the same for the wound edge. It's management of exudate, remove that non-viable tissue, because you're not going to get that springboard for that epithelial tissue to jump across the granulation. And then we've got to rehydrate the skin. So the treatment plan, if you like, was that they put the biotin silicone on, and you can see on day 7 how it conforms into the wound. It swells into the wound and makes that intimate contact with the wound base. Day 19, the granulation started to fill up. Still needs to be a bit of a protection on that wound margin. Day 56, which is quite a long way away, but because this wound had already been in existence for 8 weeks, it means we're already 8 weeks behind the ball, if you like. So 56 days, which is what, nearly 2 months, so another 8 weeks down the line, it's filled back up, and we've got epithelial contraction occurring. Case study 3. Again, sadly, this one isn't mine, but it's an immobile 51-year-old patient who's got tetraspasticity of arms and legs. He's got urinary incontinence, and he's been left with a break in the skin integrity on the sacrum. It's been there because, unfortunately, he sits in his wheelchair for 4 to 6 hours per day on a pressure relieving cushion. Now, there's nobody that can sit in one position without being repositioned. If you was to sit here today, I guarantee you would not be able to sit for 2 hours without riddling your bum around. We have to, don't we? We get a signal from our bum that says, hey up, I'm in pain. So you start doing the shuffle, don't you? You twist your legs, you move your legs like you're doing that bit of a dance. And you can't help yourself. We're doing it all the time. But for the elderly population, or those patients who are physically disabled, they may not have that message going to the brain that says, hey up, I need to move. So they just sit there. It could be a neuropathic change, or it might be that they've got the physical problem that they're getting the pain, but they haven't got the ability to move, so they're still sat there. So unless the carer, and the carer could be only 4 care calls max per day, means they're left out there for 6 hours. So even if on your dynamic piece of kit, if you're on a dynamic cushion, all that weight's going through to that point, I guarantee you're not going to last very long before your skin integrity starts to break down. So the ulcer is 6 centimetres by 3.5 by 2. It's fluffy with medium exudate, and it's got undermined, thickened edges. But I don't know whether you could see, but there's also some good epithelial contraction there. A little bit of slough in the middle that needs to be mechanically cleaned away. But the aim of the management plan is remove non-viable tissue, manage exudate, manage bacterial burden. For the wound edge, we've got to remove that non-viable tissue and protect the granulation. And for the peri-wound skin, we've got to protect it as always. Don't just discard it because it looks okay. And again, what they did with this, they put on a biotin silicone sacrum that again conformed to that wound bed, created a warm, moist environment. Therefore, it produced that autolytic set in that caused the wound to clean up, and by day 29 it all cleaned up. We've got really good granulation with that epithelial contraction coming across the wound bed, and because it's atraumatic at removal, it's not going to disturb that work that's already been done by the body and by yourselves to correct it. Case study 4 is quite a sad one, and it is back to man. This is a 90-year-old lady who lives with her husband, who was 94, I think. Basically, what she's got is pressure damage on her spine because she's got curvature of the spine. Reason being is she was sleeping still in the bed that she got married in. So this bed is probably 65 years old. And it was one of those, you know, that has the old coil things in with like horsehair across the top. And it was sticking through, and there was a bit of horsehair coming through as well. And I said to her, look, you've got this curvature of the spine, you've got this coil sticking through the bed. I said, it's caused significant damage to your back. I said, I can clean it up, but it's going to come back if you don't get off this mattress. Oh, I don't want to get off this mattress. So I said, what about just for an interim period of time? So I said, we can get you a dynamic mattress, profile in bed. No, I want to remain with my husband. We've been in it for 65 years. We're staying in this bed together. So I said, okay, that's up to you. I said, what about some respite care? When I mentioned that, husband raises his fist. He's going to have me. I thought, I fancy my chances with a 94-year-old bloke, but it could be embarrassing. So I said to her, look, if you want, I can try and clean it up and I can put a dressing on. She said, can't you just put some gaffer tape over the bed? So I said, I can't do that. No, I said, because effectively I'm agreeing to the fact that then it'll be okay. I said, if you and your family want to do that, that's up to you, and we can get you an overlay. Anyway, she said, I'd rather have that, please. So they taped it up, they got an overlay, I debrided all that away, I took all that yellow slough away, and unfortunately, as I was taking it away, all the exudate, just like thick custard, went pop, 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 and started pouring out. So she went back to being on the bed, though, sadly, afterwards, caused pressure damage again. She got sepsis and unfortunately died. So it was a bit of a, as I say, a sad story, but you know, that was what she wanted at that particular time. So characteristics very quickly of an ideal dressing are it maintains a moist environment, not wet, not dry. It manages the wound exudate, so it locks it in and it stops it from laterally wicking, causing that moisture damage around the wound margin. It should be atraumatic at removal. It shouldn't shed any fibres. It should be a good bacterial barrier. It should have good skin adhesion without causing trauma to the skin. It should aid debridement through autolysis if appropriate. It should be comfortable and conformable to all parts of the body, and it keeps the wound close to body temperature. And then ultimately the organisation will want to know, is it cost effective? Well, if it's used appropriately at the right time, right place, it will be. So you could argue, if you like, depending on that particular wound, that the biotin silicone could be the ideal wound dressing for most applications. I'm not saying it's the only one on the market, but it's the only one that does conform into the wound bed. It's the only one that locks in and stops that spread. It will work under compression as well, and there's some evidence coming out about that. It's got that 3D technology fit, which, as I say, it conforms into the wound bed, and therefore it becomes intimate with that wound margin, preventing any gaps. And it also reduces your need for that filler, which reduces your cost and therefore becomes very cost effective. Please make sure that you do document, you do communicate, and don't get yourself into a court of law where somebody's going to challenge you, because it's not a very nice place to be. As an expert witness, we have to go in and represent people that have unfortunately succumbed to wounds, and then there's that challenge made by the family or by the trust or some other organisation. Please make sure you document. Please make sure you communicate, not just with each other, but with the carers, because the carers are the ones that are looking after that person a lot more often than you are. You're going in maybe only once or twice a week for a max of half an hour at a go. They're going in 4 times a day potentially, or it could be the next of kin. So if we're not communicating what our expectation is of them, they'll just say, nobody said anything. If it's not documented, if it's not given in a leaflet, no, it wasn't us, we didn't do it. And us, as the registered nurses, registered professionals, be it podiatry, whoever, it'll come back to us. The NHS investigates us, that's all. So please make sure you protect yourself. So in conclusion, choosing the right dressing at the right time for the right length of time is critical in attempting to achieve the aims and objectives for the wound and the patient. Don't think of Joe the wound, think of Joe the holistic patient. We must use a systematic, evidence-based approach to wound management, which is where the triangle of wound assessment comes in. We should also work with the multidisciplinary team to ensure that the root cause of the wound is addressed. Thank you very much for coming, and have your break, and thank you.